My name is Ann Woolley, and I'm in the Infectious Diseases Division at Brigham and Women's Hospital in Boston, Massachusetts. I will be speaking today on infective endocarditis. I do not have any financial disclosures. The way I have structured this talk is to first spend time talking about native valve endocarditis, and then I'll highlight some of the unique differences with prosthetic valve endocarditis, followed by then discussing what are the indications for surgery and the timing of surgery. We'll then discuss cardiac implantable device infections and end with the recommendations on who should have antibiotic prophylaxis prior to dental procedures. So to begin, I'd like to start with a question. Which of the following is the most common bacterial etiology of infective endocarditis? 1. Streptococcus mutans. 2. Streptococcus sanguis. 3. Group A beta hemolytic streptococcus. 4. Enterococcus faecalis. Or 5. Staphylococcus aureus. The answer is Staph aureus. Now, for my second question, I'd like to have it be the inverse and ask, when bacteremia is documented, which of the following is the least likely to be associated with endocarditis? Streptococcus mutans, Streptococcus catalyticus, Streptococcus mitis, Group A beta hemolytic streptococcus, or Enterococcus faecalis. The answer is Group A beta hemolytic strep. As you see, at this time we talked about 4 different types of strep. And so it's not a case that Streptococcus, your takeaway should not be that Streptococcus is least likely to be associated with endocarditis. However, of the different Streptococcus species, the Group A beta hemolytic streptococcus is least likely to be associated. Why is this important? Well, it's important to know the etiology of native valve endocarditis when we think about what empiric antibiotic regimen to use for a patient that has native valve endocarditis before we get the culture results back. The large percentage being Staph aureus, followed by Streptococcus, though there are many different species of Streptococcus, and hence why on the prior slide it was important to know which of the Streptococcus was least likely to be involved. Then Enterococcus makes up about 10% of cases, followed closely behind that with coagulase negative staph. And then you have the Haysick and the gram-negative rods making up about 3 to 4% of cases, followed by polymicrobial. It's very rare to have Candida endocarditis, and then about 6% of the cases are culture-negative endocarditis. How does this differ in our patients that have native valve endocarditis with a history of injection drug use? Well, you see here I've laid out the organisms and then compared that for right-sided versus left-sided endocarditis. For right-sided endocarditis in patients who inject drugs and have native valve endocarditis, 3/4 of those cases will be due to Staph aureus. As compared to on the left side endocarditis, the majority will have either Staph aureus or Enterococcus, followed behind both of those with Streptococcus. Then there's a larger percentage of gram-negative bacilli, and Candida is 12%. As compared to in all patients that have native valve endocarditis, as we recalled in the prior slide, that was just 1%, and then 3% culture negative. Now this regards the organisms that are involved in endocarditis, but how do we go about diagnosing someone with infective carditis? We use the modified Duke criteria. So that's laid out into definite infective endocarditis, possible infective endocarditis, or presumed but rejected and the patient does not have infective endocarditis. To have definite endocarditis, you must either have pathologic criteria, meaning that you have a positive culture or histology of vegetation or intracardiac abscess, or we use the Duke criteria to see if they meet the clinical criteria, meaning that they have 2 major or 1 major plus 3 minor, or 5 minor, and we will get to what those major and minor criteria are in the follow-up slides. If you don't have definite infective endocarditis, but you think there is possible infective endocarditis, then the patient must have 1 major and 1 minor criteria, or 3 minor criteria. However, if you have an alternative diagnosis or no pathologic evidence of endocarditis is found after the patient's been on antibiotics for less than 4 days, and does not meet criteria for possible or definite infective endocarditis, then the patient does not have infective endocarditis. So when we get to what the DO criteria is to diagnosis, let me start with a question. Which of the following is not a major criterion in the modified DO criteria for the diagnosis of infective endocarditis? 1. A typical organism consistent with endocarditis from 2 separate blood cultures in absence of a primary focus. 2. Having an anti-phase 1 IgG antibody titer for Coxiella-Burnetti that is greater than 1 to 800. 3. An oscillating intracardiac mass on a valve or supporting structure seen on echo, an abscess or dehiscence of a prosthetic valve. Or 4. A worsening or changing pre-existing regurgitation murmur. The answer is 4. It is not enough to have a worsening or changing pre-existing regurgitation murmur. You must have a new valvular regurgitation. So what are the major criteria for the diagnosis of infective endocarditis according to the modified DO criteria? You must have at least 3 sets of blood cultures from different sites with first and last blood cultures being drawn at least 1 hour apart that are positive, and evidence of endocardial involvement, meaning that you have either mobile echo density on an echo or new valvular regurgitation. Again, it is not enough to have worsening of prior regurgitation. It must be a new valvular regurgitation. Well, when we talk about blood cultures, it doesn't matter what the organism is. Well, the typical organisms are Staph aureus, Viridans group strep, Streptococcus catalyticus, which was formerly Streptococcus bovis. We can't forget about the nutritionally variant strains of Streptococcus, Granulocytella, or Abiotrophia are the 2 most common ones, though they are rare overall. And then the Haysick group. Well, when we talk about Haysick group, which organisms should you know? Haemophilus, Eikenella, and Kingella, you should remember of those 5. And then also community-acquired Enterococcus. You must have persistently positive blood cultures, and that means for organisms that are typical causes of endocarditis, you must have at least 2 positive blood cultures from blood samples drawn more than 12 hours apart. And then again, if you have the anti-phase 1 IgG antibody titer for Coxiella-Burnetti that's greater than 1 to 800. Well, what about the minor criteria for the diagnosis of endocarditis? 1 is a predisposing heart condition or history of intravenous drug use. A fever, and that is defined by a temperature greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. Vascular phenomenon, either an arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, which is what's seen in that top photo, or Janeway lesions. Or evidence of immunologic phenomena, and that's either glomerulonephritis, Osler's nodes, which is a third photo, Roth spots, which is that middle photo, or rheumatoid factor. Another minor criteria is having a positive blood cultures that do not meet the major criteria, or serologic evidence of active infection with organisms consistent with infective endocarditis. Another minor criteria is you have echo, minor criteria eliminated. So now what if you suspect infective endocarditis? How do you then go about what your workup should be? Let's first go to the low initial patient risks that have a low clinical suspicion. Let's first look at that, and you would initially get a transthoracic echo. If the transthoracic echo did not show any valvular or mobile echo densities seen on the valves, but you still had increased suspicion during the clinical course, that would then press you to want to get a transesophageal echo. If that were then positive, then you would go ahead and treat. If the initial transthoracic echo is positive, then you go ahead and treat at that point. Whether or not to then go on to get a transesophageal echo after your transthoracic echo is positive has to do with whether or not there are high-risk echo features that were seen on transthoracic. Now, what if the patient had a high initial risk and you had moderate to high clinical suspicion, or they were a difficult imaging candidate? Well, you initially get the transthoracic echo, and then you would want to get a transesophageal echo as soon as possible. So really to determine whether or not you proceed with a transesophageal echo off the bat after getting that initial transthoracic right away, really has to do with whether or not the patient is risk stratified as a high-risk patient. If those are positive, you then treat. If they are negative, but you still have a high suspicion, you then should repeat the transesophageal echo. And then if that is negative, then you look for another source. You should have a follow-up transesophageal or transthoracic to reassess vegetations, complications, or treatment response if clinically warranted. We talked initially about the fact that Staph aureus is the most common organism associated with native valve endocarditis. Well, how do we treat that? I want to point out here, as we know, we can have methicillin-susceptible Staph aureus or methicillin-resistant Staph aureus. In the cases of methicillin-susceptible, you can either treat with nafcillin or oxacillin or cefazolin. It used to be that nafcillin or oxacillin were by far the preferred agents. Now, cefazolin has been seen to not be inferior and to also have less side effects or adverse events seen with the patients, and therefore either are appropriate first-line treatments. The treatment duration is 6 weeks of treatment. It should be noted that if you had uncomplicated right-sided infective endocarditis, the native valve, then you may be able to get away with just 2 weeks of treatment. For MRSA, native valve endocarditis, our go-to is vancomycin for 6 weeks, or an alternative to that is daptomycin for 6 weeks. If the patient has a beta-lactam allergy or hypersensitivity, then you would use vancomycin in our methicillin-susceptible Staph aureus cases as well. It is important to know that there is not an indication for using gentamicin or rifampin in native valve Staph aureus treatment. While there is an indication to use gentamicin in prosthetic valve Staph aureus endocarditis, rifampin needs to be reserved for once the patient has cleared their blood cultures, because rifampin has a very low barrier to resistance, and therefore you do not want to be treating patients with rifampin if you can avoid it when the patient is actively bacteremic, because then you will just get resistance to that antibiotic. Now let's review the causes for culture-negative endocarditis. As we reviewed earlier, about 6% of all native valve endocarditis cases are culture-negative. Well, what's the most common reason for having culture-negative endocarditis? It's the fact that the patients were started on antibiotics prior to blood cultures being drawn, and therefore the blood cultures are never positive. Some other reasons for having culture-negative endocarditis in patients who were not started on antibiotics prior to obtaining cultures is that you have fastidious organisms, or ones that are historically a little bit harder to culture, such as the Haysick organisms that we reviewed, or the nutritionally variant Streptococcus organisms, such as Granulocytella or Abiotrophia, or the Brucella species. Then we have some that we refer to as the non-cultivitable organisms, such as Bortonella, Coxiella, and some of the others that I have listed there. Fungal, such as molds, not referring to Canada here, but the molds. Or the patient actually doesn't have infective endocarditis. They might have Libin-Sachs or myxoma, or Marantic, or a tumor. I would like to just quickly review the empiric antibiotic treatments for culture-negative endocarditis. And these regimens have been recommended based on what the more commonly causes of culture-negative endocarditis is, and again, keeping in mind that this is trying to target organisms for which we believe are the likely cause of endocarditis, but we weren't able to culture either because they were started on antibiotics prior to cultures being drawn, or they were not had enough cultures drawn initially before being on treatment. And so the empiric antibiotic treatments for acute clinical presentation is vancomycin plus cefepime. But if the patient has a subacute clinical presentations, then it's recommended vancomycin plus ampicillin sulbactam or vancomycin plus ceftriaxone. The reason for the difference is that for the subacute clinical presentations, we think more about the Haysick organisms, and so we want to target those. As compared to acute clinical presentations, we're not as concerned about those. Now we'll touch on a few slides for prosthetic valve endocarditis. So what are some of the differences in the presentations of prosthetic valve endocarditis as compared to native valve endocarditis? Well, they both have similar presentations, but there are different microbiologic causes of prosthetic valve endocarditis that I will get to in the next slide. And prosthetic valve endocarditis are usually more invasive infections. They usually have higher rates of leading to heart failure, conduction disturbances, new or changing murmurs, and associated cerebral infarcts. So what are the microbiologic causes of prosthetic valve endocarditis? Well, in patients that have endocarditis of the prosthetic valve less than 2 months after having the prosthetic valve placed, the most likely causes are coag-negative staph, followed by Staph aureus. And these other 4 are much less common: gram-negative rods, enterococcus, fungal, or diphtheroids. Whereas if patients that have prosthetic valve endocarditis after a year of having the prosthetic valve placed, then they are more likely to have Viridans strep group endocarditis, followed by Staph aureus, and then followed by coag-negative staph, and then, less commonly, enterococcus, gram-negative rods, Candida, and diphtheroids. Now I'd like to go on to talk about the indications for surgical management of endocarditis. So the indications for surgery include heart failure due to valvular dysfunction, the presence of heart block, or annular or aortic abscesses. If the organism causing endocarditis is due to a fungus, gram-negative rods, or a highly resistant organism, such as vancomycin-resistant enterococcus, or a multi-drug resistant gram-negative rod. If the patient has persistent bacteremia or fevers greater than 7 days, despite being on antibiotics and not having another attributable alternative source. If the patient has evidence of emboli or large vegetations, and that's defined as a vegetation being greater than 10 millimeters. Or if this is a relapse and a recurrent prosthetic valve endocarditis again. Well, what is the embolization risk in general for both native and prosthetic valve endocarditis? So this paper from 2001 compared the percent of embolic events that were seen compared to what the size of the vegetation was. And as you see, the percent of embolic events significantly increases as the vegetation size increases above 10 millimeters. The highest risk of having emboli occurs when the patient has anterior mitral valve involvement, prosthetic valve involvement, or when the organisms causing endocarditis are either a Staph aureus, a Candida species, or one of the Hayseck species. It's important to note that there is a marked decrease in embolic rates that have been seen after 2 to 3 weeks of being on antibiotic treatment. Well, how does the size of the vegetation impact a patient's survival? The incidence of embolic events and death is still high in patients with infective endocarditis, and data about predictors of these 2 major complications have been conflicting in the literature. In 2005, this paper was published in Circulation. There was a multi-center prospective European study that included 384 patients that had definite infective endocarditis according to the modified Duke criteria. And they looked at when embolisms occurred before or after infective endocarditis diagnosis, after initiation of antibiotic therapy. Staph aureus and Streptococcus bovis were independently associated with having a greater number of embolic events. And what they concluded is that the vegetation length was a strong predictor of having new embolic events and mortality. So in combination with clinical and microbiologic findings, the ECHO may identify high-risk patients who would need more aggressive therapeutic strategy, given the fact that the length of the vegetation did in fact predict 1-year survival. Well, so now, when should we recommend surgical intervention? Do we know what the optimal timing is? The short answer is no, we don't. But I will take us through a study that attempted to look at this. So there was a study that was published involving 2 centers in Korea. in 2012 in the New England Journal of Medicine that looked at early surgery versus conventional treatment for endocarditis. There were 76 patients in the study. It involved patients that had left-sided native valve endocarditis with severe valvular disease and large vegetations. The patients were randomized to either early surgery or conventional treatment. 60% of the cases were due to streptococcus, only 10% were due to Staph aureus, very few were due to enterococcus, and then they had a larger than usual percentage that we're used to seeing for culture negative of about 20 to 30%. The primary endpoint was a composite of in-hospital death and embolic events that occurred within 6 weeks after randomization. There was no significant difference in all-cause mortality at 6 months in the early surgery and conventional treatment groups, but the rate of the composite endpoint of death from any cause, embolic events, or recurrence of infective endocarditis at 6 months was 3% in the early surgery group and 28% in the conventional treatment group. Therefore, it was determined that early surgery in patients with infective endocarditis and large vegetations significantly reduced the composite endpoint of death from any cause and embolic events by effectively decreasing the risk of systemic embolism. Well, now, what do we do as far as our recommendations to our surgical colleagues as far as having a valve replacement when the patient already has had a CNS infarct? There was a study that looked at 240 patients that had infective endocarditis and a CNS infarct who then underwent valve replacement. It looked at the risk of neurologic deterioration after the valve was replaced. This was a retrospective study for the majority of the patients, though 12 patients were at the center, and then the rest of the patients were retrospectively looked at. And what they looked at was that for patients that already had a CNS infarct and endocarditis prior to surgery, if surgery was done within 3 days of their diagnosis of endocarditis, there was about a 20% risk of neurologic deterioration after surgery. But you see how that significantly decreases after 4 weeks and is less than 1%. So they concluded that patients with infective endocarditis and heart failure and with a CNS infarct, the surgery should be performed either right away within the first 3 days of the infarct or delayed until more than 4 weeks after the infarct while on medical management. This obviously requires a lot more study and more of a trial to be able to understand this better. However, this was some data to actually lead us to say if surgery can't be done right initially, is it actually better to wait to not risk the neurologic deterioration after surgery? Obviously, the timing of surgery needs to be taken into account with overall the patient's comorbidities, how they're clinically doing, whether or not they're still having persistent bacteremia, and all the other indications for surgery that we already have discussed, and obviously in keeping with what the surgical colleagues recommend. So in the guidelines that were published in Circulation 2015 for valve surgery in patients with prior emboli, hemorrhage, or stroke, the recommendations are as follows. The valve surgery may be considered in infective endocarditis patients with stroke or subclinical cerebral emboli and residual vegetation without delay if intracranial hemorrhage has been excluded by imaging studies and neurologic damage is not severe. However, in patients with major ischemic stroke or intracranial hemorrhage, it is reasonable to delay valve surgery for at least 4 weeks. It's important to note, though, that the impact that valve surgery has on survival in patients with endocarditis is quite great. So as you see here from this paper from 2011, the surgical group, this Kaplan-Meier curve, the surgical group compared to the non-surgical group had a much greater percentage of surviving patients at the 5-year mark. And that curve separates early on after a few months. Now I'd like to transition to talking about management of the cardiac implantable device infections. So let's start like we did for endocarditis with the cardiac implantable device infections and talk about what organisms are most likely to cause these. So about 42% of cases are due to coagulase negative staph, followed by Staph aureus making up about 30%. And then gram-negative rods, polymicrobial, and culture negative each make up 9% and 7% and 7% respectively. And then it's rare to have fungal causes, which make up just about 2%. Let's talk about what types of cardiac implantable device infections we have and how we define these. So you may have just a pocket site only infection, which make up about 60% or so. Of those pocket site only, less than half will have a positive blood culture. And with the pocket infection, you may have a generator lead or erosion due to the generator or the lead. Anywhere from 7 to 30% or have occult bacteremia or fungemia, and these are patients that have a cardiac implantable device in place and then have occult bacteremia or fungemia. And then about 10 to 25% will have a lead infection either with or without endocarditis. So in 2007, a paper was published that discussed the algorithm for how we manage these patients that have infected cardiac implantable devices. So if you suspect an infection in patients that have a cardiac implantable device, you then want to get blood cultures. If they're positive, then you need to go on to get a transesophageal echo to then see if there is a valve vegetation or not. If your blood cultures are negative, then you look to see if it's just a pocket infection or is it a generator/lead erosion. If it's either of those cases, your treatment course is much less, being anywhere from 7 to 10 days for generator lead erosion or 10 to 14 days for pocket infection. Whereas if you have a lead vegetation and a positive blood culture and it's uncomplicated, then you determine whether or not it is a Staph aureus species or not. If you have a complicated positive TEE that shows a lead vegetation with septic venous thrombosis or osteomyelitis or another embolic event, then you want to treat with 4 to 6 weeks of antibiotics, usually erring on the longer side, depending on what the organism is. So now, what do we do with this? So let's say you have a positive blood culture and a positive transesophageal echo. Then you want to repeat the blood cultures after you remove the device. That includes the generator and the leads. If you have a valve vegetation, then it's recommended that you implant the new device after 14 days from the first negative blood culture. If you only have a lead vegetation and not a valvular vegetation, then it's recommended that you implant the new device if repeat blood cultures remain negative for 72 hours. If you have blood cultures that are positive, but no evidence of valvular or lead vegetations on echo, then you want to repeat the blood cultures after the device is removed, and you can implant it if repeat blood cultures are negative for at least 72 hours. If you just have a generator pocket infection or a generator or lead erosion, you have negative blood cultures for 72 hours, then you can implant the device. So in summary, you want to wait at least 72 hours after you removed the device and you've had negative blood cultures before implanting it, unless you have a valvular vegetation, and then it's recommended you wait 2 weeks. These recommendations may or may not change or evolve as we are now placing more leadless pacemakers. So the current AHA guidelines for management of these infections includes device removal for all infections, and if the patient does not have any evidence of a lead, valvular, or pocket infection, but they have occult staphylococcal then the device should be removed. You should also think about whether or not you should remove the device if the patient has gram-negative rod bacteremia. The duration of treatment depends first on what infection you have. If you just have a pocket infection, then as we discussed, that can range anywhere from 10 to 14 days. If you have a bloodstream infection, then you're talking at least more than 2 weeks. And if you have a lead or valve vegetation, then you're talking anywhere from 4 to 6 weeks. What antibiotic you use is then, of course, based on which organism is causing this and the susceptibility of that organism. The AHA guidelines for reimplantation says, first and foremost, determine if reimplantation is necessary. Then, if you can, place a new device on the contralateral side. And again, as we highlighted, you want to wait more than 72 hours of negative blood cultures prior to reimplantation. Or if there is evidence of valvular endocarditis, then you want to reimplant the device greater than 14 days after removal. I'd now like to end with talking about what are the recommendations for who requires antibiotic prophylaxis prior to dental procedures. So there were changes in these recommendations, and the rationale for this is that bacteremia can be caused not only with patients that undergo dental procedures, but just from toothbrushing. And we saw that toothbrushing is 154,000 times greater per year than is having a single extraction to cause bacteremia. So why are we just focusing on dental work rather than just daily toothbrushing? We know that antibiotics do not eliminate bacteremia, and it's not even clear whether they reduce the rates of infective endocarditis. There's no prospective studies to date that support the efficacy of prophylaxis, antibiotic prophylaxis prior to dental work. There was a case control study done that showed that a dental event did not increase the incidence of endocarditis. So therefore, it's important to note that we should not over-prescribe antibiotic prophylaxis, but these are the patients in which is still recommended by the AHA that we do prescribe antibiotic prophylaxis. Any patient that has a prosthetic valve or prosthetic cardiac material, if they've had history of prior endocarditis, and then what also has changed is in the patients that have history of congenital heart disease. It's only recommended in those that have an unrepaired cyanotic congenital heart disease, including shunts or conduits. If they have a repaired congenital heart disease but have prosthetic material and it's less than 6 months from the procedure, a repaired congenital heart disease with residual defects. And then for our cardiac transplant recipients, it's only recommended in those transplant recipients that have evidence of valvular disease. Well, what should we use as the prophylactic regimens? So the majority of patients, it's recommended that they be treated with amoxicillin 2 grams, and that should be given 30 to 60 minutes prior to the dental procedure. If they need IV antibiotics for some reason, then ampicillin or ceftriaxone can be used as alternatives. For those patients that have an allergy to penicillin, you want to think about clindamycin or azithromycin. Here are the references from the studies that I've already spoken about throughout this presentation. So now that ends the presentation and the talk, but now I'd like to just complete this by going through 3 summary questions to highlight some of the major points I was trying to review. Question 1. You have a 63-year-old gentleman without any significant past medical history who presents with a week of fevers, rigors, and progressive dyspnea on exertion. On exam, he is febrile with a temperature of 39.5 degrees Celsius, blood pressure 160/40, and he's tachycardic with a heart rate of 110. On exam, you see that he has an elevated JVP. He has conjunctival hemorrhage. He has, in the second picture there, we can see that he has Janeway lesions. He has bilateral rales on exam and a loud diastolic decrescendo murmur that's loudest at the lower left sternal border. And then you obtain chest imaging, which shows that he has imaging concerns of a pulmonary septic emboli. Which of the following is the most appropriate empirical regimen for this patient? To answer this question, you want to keep in mind what we talked about as the most common organisms for causing endocarditis. And that would be B, cefazolin plus vancomycin, targeting both MSSA and MRSA, as well as streptococcus. Question 2. 71-year-old gentleman with a permanent pacemaker that had been implanted 2 months ago for sick sinus syndrome and syncopal episodes, who presents with fevers. On exam, he's febrile to 37.9 degrees Celsius, a blood pressure of 122/75, and his heart rate is 76 and paced. He has a generator pocket that is slightly tender and edematous with moderate warmth and erythema around it. For cultures, you have blood cultures that are negative, and then there's purulence that is aspirated from the pocket, and that grows methicillin-susceptible Staph aureus. Which is the best management and treatment for this patient's infection? A, cefazolin plus rifampin for 6 weeks. B, remove the generator and treat with cefazolin plus rifampin for 10 days. C, remove the generator and treat with cefazolin plus rifampin for 6 weeks. D, remove the entire device and treat with cefazolin plus rifampin for 6 weeks. E, remove the entire device and treat with cefazolin for 10 days. The answer is E, remove the entire device and treat with cefazolin for 10 days. And for our last question, which of the following patients should receive prophylactic antibiotics? A 50-year-old gentleman with mitral valve prolapse and severe mitral regurgitation undergoing dental cleaning. B, a 65-year-old woman with prior cyanotic congenital heart disease that was successfully repaired many years ago. C, a 56-year-old gentleman with history of ischemic cardiomyopathy whose status post a cardiac transplant 6 months ago. D, a 47-year-old with prior history of endocarditis who's undergoing periodontal surgery. The answer is D. C is not the answer because the patient that has a history of a cardiac transplant does not have any history of valvulopathy. B is not the answer because though the patient has a history of prior cyanotic congenital heart disease, it was successfully repaired without any material in place and it was done many years ago.